In the previous video, you learned about action potential, which is how signal is transmitted down the axon. Now we're going to look at how the signal will jump from one neuron to the next neuron. So let's take this note together. Um, let's take a look at what happens when the signal gets to the axon terminal of one neuron. So here is one neuron, and this is the axon, and this is the axon terminal, and I'm going to draw another neuron here, another neuron. Okay, so there, that would be the dendrite, and we know how the action potential will go down the axon. And the question is, how does the signal jump from the axon terminal of one axon, of one neuron, to the dendrite of the next? So in this scenario, this neuron here is going to be called the presynaptic cell. Presynaptic cell. That's the one that is going to be carrying the signal. And here, the one that is going to be receiving the signal is called the postsynaptic cell. So the signal will jump from the axon terminal of the presynaptic cell to the dendrite of the postsynaptic cell. Now the two neurons are not in physical contact. Okay, they just come really close to each other. And if I were to zoom in to this region where they are really close together, then I can draw a bigger picture. So here we will have the axon terminal of the presynaptic cell, and over here we will have the dendrite of the postsynaptic cell. Okay, so this gap here, this gap is called the synaptic cleft. Synaptic cleft. So together, the axon terminal, the synaptic cleft, and the dendrite, that makes up a synapse. So here we have a neuronal synapse. Okay, that's the title of the node. Now there are other type of synapses. There are neuromuscular junction or synapse. That's a connection between a neuron and a muscle. But now we're just going to be looking at the connection between a neuron and another neuron. Okay, so we have the axon action potential coming down from the axon. So what's going to happen? What's going to happen next? Okay, so it turns out at the axon terminal, you are going to have these vesicles. Okay, and in the vesicles, you are going to have some chemicals called neurotransmitters. So I'm going to use these blue dots. I'm going to draw them there. So these neurotransmitters are a lot of times pre-made, and they are stored in vesicles in the axon terminal. So they are called neurotransmitters. And neurotransmitters, or NT, they are basically chemicals used for neuronal communication. Yeah, so some neurotransmitters are excitatory; they transmit green signals, so to speak. Right? Remember our neuron label earlier. Over here, right? There are some excitatory signals. There are some inhibitory signals, right? So these are actually conveyed by neurotransmitters. So some neurotransmitters will have excitatory effects on the next neuron. Others, they will have inhibitory effects. Okay, and some neurotransmitters will be both excitatory or inhibitory, depending on which region of the brain we are talking about. Some examples of neurotransmitters that you might have heard of include things like dopamine. You might have heard of dopamine as the happy hormone is actually a neurotransmitters. There are something called serotonin, for example. And so in order for the neuron to respond to the neurotransmitters, they must have the appropriate receptor. So there is a key and lock relationship between the neurotransmitters and the receptors that they're going to bind to. So on the dendrites, if it's going to be able to respond to these blue neurotransmitters, you will have a blue receptor. Okay, so of course I'm just using color to make it simple to understand. In reality, if these blue neurotransmitters are dopamine, then you would have a dopaminergic receptors. Okay, so remember there are hundreds of other neurons in the same proximity. Okay, so if there is another neuron here, if there's another neuron here, okay, and this neuron, the dendrites, only have say pink receptors. Even though there are blue neurotransmitters in the area, they won't be able to respond to it. Okay, you must have the right receptor in order to respond to the particular type of neurotransmitters. Okay, so what's going to happen is along the axon, we learned that there are these voltage sensitive sodium channels and voltage sensitive potassium channels. Well, at the axon terminal, there is other types of channels, and these are going to be the voltage sensitive calcium channels. Okay, so these are calcium channels. Okay, so what's going to happen is the action potential will arrive. And that will cause the membrane charge to change, and that will trigger the calcium channels to open. Okay, so they are closed right now. So when the action potential arrives, then the calcium channels sorry about that. Then the calcium channels is going to help it open, and when the calcium channel opens, the calcium will move into the axon terminal. Okay. Once the calcium goes into the axon terminal, then the calcium will bind to these vesicles. Okay, so the purpose of the calcium is to push these vesicles towards the edge of the axon terminal. Okay, so once the calcium binds to it, this thing is going to, let's see if I can do this. This thing is going to move towards the edge. Okay, like that. Okay, and all of these will move towards the edge. And when they do move towards the edge, what's going to happen is the vesicle is going to fuse with the membrane. Okay, it's going to fuse with the membrane. Just choose the right color here. Okay, they're going to fuse with the membrane and is going to basically do exocytosis. Okay, they are going to release the contents of the vesicle, and in this case, those are going to be the neurotransmitters. Okay, so the neurotransmitters is going to go into the synaptic cleft. Okay, so just quickly recap what happened so far. Right, so number one, we have the action potential arriving at the axon terminal. Number two, we have the opening of the calcium channels. Number three, we have the influx of the calcium ions. And then number four, we have the release of the neurotransmitters. Okay, so what's going to happen next? Next, if the dendrite has the correct receptor, then the neurotransmitters, the blue one in this case, will bind to the receptor. Now, we talked about voltage sensitive channels. These are ion channels that will open when the membrane potential reach a particular voltage. Over here, we have what's called chemically gated sodium channels. So they are basically sodium channels that will open when a particular chemical binds to it. And in this case, that chemical is going to be the appropriate neurotransmitters. So number five is that the neurotransmitter will bind to the appropriate receptor, and that will cause it to open. Okay, to open. And as soon as the sodium channels open, then it will cause the sodium to move into the cell. Okay, and if enough sodium move into the cell, then it is going to cause the inside to become positive, and that will trigger the action potential in the next cell. Okay, that's basically how the signal goes from one neuron to the next. And again, this all happens at the neuronal synapse, which is where one neuron comes into close proximity with another neuron. In this picture, this diagram is basically what we drew together just now. This is just more professional drawing, I guess. So we can see that there is the neuron here, and there are multiple axon terminals connected to it. Some convey excitatory signals using neurotransmitters that would be excitatory. Others would be carrying inhibitory signals. If we zoom into that region, we will see that there is the axon terminal, and as the action potential arrives, it's going to trigger calcium channels to open, and the calcium will come in to the axon terminal. The calcium are represented by these yellow dots. They will bind to the vesicles containing neurotransmitters, and the calcium will push the vesicles towards the edge, causing them to fuse with the membrane and then releasing the neurotransmitters into the cleft. And if we zoom into what's happening in the cleft, the neurotransmitters, which are shown here by the blue balls, they will bind to the appropriate receptor, and these receptors are chemically gated, which means when the correct neurotransmitter binds to it, they will open, and the sodium will then be able to move into the next cell, triggering an action potential. So after the neurotransmitter has exerted their effects, they will need to be removed from the synaptic cleft. If we don't remove the neurotransmitter, then they will continue to transmit the same signal over and over again, and that's not a good thing. Imagine touching a hot surface, and even after you remove the hand, you feel the same initial intensity of the burn. Right? That would not be a good thing. And so, removing neurotransmitter from the synaptic cleft is necessary to avoid sustained transmission of the same signal repeatedly. Okay, and so we can remove the neurotransmitters in one of two ways. They can be broken down enzymatically. Sometimes the receptor that they bind to has a built-in enzymatic function, and so after it binds, it would break it down almost immediately. Other times, we have glial cells in the surrounding area that will secrete enzyme to break them down. Another way to remove the neurotransmitter is just to simply reabsorb them back into the presynaptic cell. So doing endocytosis essentially, right? Take back the neurotransmitters, package them into vesicles again, so next time when you need them, you can just release them again. And sometimes the glial cells will help with the reabsorption of the neurotransmitters. Let's end the lecture with some neurological disorders. A lot of times the disorders of nervous system involve some kind of disruption of signaling at the synapse, and if you disrupt the communication at the synapses, it will create different problems depending on what the disruption is, and a lot of the symptoms of many neurological disorders actually arise from lowered level of neurotransmitters. So if you do not have enough neurotransmitters of a particular type, then usually you're going to have some kind of neurological problem. So how do you fix something like that? Well, if you don't have enough neurotransmitter of a particular type, then the logical thing to do is to try to increase the level of the missing neurotransmitter. But as I will explain in the next example, that's not always possible. And so we will try to prolong the activity of the neurotransmitter at the synapse. Okay, so if we cannot boost the level of neurotransmitters, then maybe we can prevent their breakdown at the synapse and thereby prolonging their effects. So we're going to look at two examples. The first one is dopamine. So dopamine is a neurotransmitter that has inhibitory effects in a region of the brain called the substantia nigra. Okay, so in this brain scan, it shows you where the substantia nigra is, and in a normal individual, these inhibitory effect is important for allowing precise control of movements. Okay, so by suppressing the substantia nigra, you can inhibit unwanted movements, and that's important when you want to have very precise fine control for, say, writing. Okay, and then what happens is in someone who has Parkinson's disease, we can see that there is a decrease in dopamine level at the substantia nigra. So here's the same scan in someone with Parkinson's disease, and you can see that the lack of red is essentially telling you there is not a lot of dopaminergic activity there. And so without those inhibitory effects, you are not going to be able to suppress unwanted movement. And of course, one of the characteristics of Parkinson's disease are those involuntary trauma. So how do we fix that? If the problem is not having enough dopamine, how do we fix the problem? Well, the logical thing to do is perhaps to give the person dopamine. But the challenge is this: you have something called the blood-brain barrier in the nervous system that will prevent certain things in the blood to gain entry to the brain. And if you give people dopamine, they are not going to be able to cross the blood-brain barrier, and they would not be able to go into the brain where it is needed. And so it's not as straightforward as giving someone dopamine to boost the level. So instead, the pharmaceutical company have developed something called levodopa. Levodopa is considered as the first-line medicine for Parkinson's disease. It's not dopamine itself, but it's the building block for dopamine. Okay, so the drug is designed to be able to cross the BBB, the blood-brain barrier, and once it's taken up into the brain, brain cells can use it to manufacture dopamine. Okay, as with most medicine for neurological disorder, your brain has a way of adapting to these medications, and so they lose their effectiveness over time. It's kind of like drinking coffee, right? If you're a coffee drinker, first time you drink it, it keeps you up all day, right? And perhaps keeps you up all night as well. But eventually, over the years, you have to drink more and more in order to feel the effects of the caffeine, and that's the case for these drugs. So eventually, the drugs would be completely useless for you if you take it for a long time. Right? You cannot indefinitely increase the dose, right, because of side effects, for example. So it will eventually lose the effectiveness in this case. So there are no treatment for Parkinson. We only have medication to kind of improve the quality of life, and there's no permanent treatment, no permanent cure for Parkinson's disease. Another option is to do what's called deep brain stimulation. For some people who are experiencing really bad symptoms and there are no other good options, one thing to do is to implant electrical electrodes into the region close to the substantia nigra. So what happens is in deep brain stimulation, the surgeon is going to open up the brain of the patient, and they actually have to do it with the patient conscious. Right? It sounds really scary, but then there are actually no pain receptors in the brain, so you won't feel the pain from the actual brain operation. They would just put local anesthetics in your scalp, so when they cut it open you don't feel the pain that way, but inside the brain there are no pain receptors actually. So the surgeon is going to ask the patient to talk and to do certain simple movements, and if this is a Parkinson patient, then there might be some stuttering in the speech, for example, and then there will be trauma in the hand. But when the surgeon stimulate the right location of the brain, they could see in real time that the stuttering is improving, or the trauma has been reduced, right? So that's how they identify which region of the brain requires stimulation. Once that location is identified, they would implant a little electrode, kind of like a pacemaker, for the heart, and then they would close up everything, and then the pacemaker will regularly deliver electrical stimulation to that region of the brain to manage the symptoms. Of course, this is a very high risk operation because you're opening up the brain and then implanting stuff. So it's not an option for everybody, but it is one possible option. Another example we're going to look at is serotonin. Right, so serotonin, the short form is 5-HT. It's a neurotransmitter that includes a bunch of functions, and you can read them all here. And one of the function is controlling mood. And so it has been shown that a decrease in serotonin level are linked to clinical depression. Right? So how do we fix something like that? One of the top-selling drugs in North America has been this drug called Prozac. And Prozac is an antidepressant, and it actually belongs to a class of drug called SSRI, which stands for stands for selective serotonin reuptake inhibitors. Basically, they work by blocking the reuptake of serotonin. So let me just refresh your memory a little bit. Normally, what happens is the action potential would come, and calcium comes in, and you will release the serotonin into the synaptic cleft, and then they would be reabsorbed back in, because we need to remove the neurotransmitters from the cleft, right? So the problem here with clinical depression is we don't have enough serotonin, so we want to block the reuptake of the serotonin. You don't want them to go back into the vesicles too quickly, right? So by taking the Prozac, it will interfere with the reuptake process, and so the serotonin can hang out in the synaptic cleft a little bit longer, and therefore exert their effect a little bit longer. Okay, so basically in Parkinson's disease we have lower than normal dopamine level, right? That's the problem. And in clinical depression we have lower than normal serotonin level. That's it for this lecture. Thank you for watching.